Really good to see everybody online. And we have still registrants coming in, all right? But I just want to first welcome everybody to join this seminar, which is normally people are having lunch. And I guess this is really good sign that everybody is still learning during the lunchtime. So I really would have a big appreciation of everybody's, the lifelong learning attitude. All right, all right, and it's at lunchtime. Uh, so first thing, I'm Dr. Andrew Seal, who is the moderator today, just to keep the time and to receive the questions and so on, organize the other things. But the first thing I need to do is to introduce our speaker today, who is Dr. Wing Chen. He's already shown his face and check with you about his voice. Um, Dr. Chen is not a new colleague of us. He has been working in our department in between 2013 to 2015, and we are so glad he returned to our family again recently as assistant professor. Dr. Chen is a physiotherapist and a specialist in geriatrics. He earned his master's in gerontology and also PhD in this area in the CUHK, right, Chinese University. And during that time, he has also won the fellowship award to support his which is a SH Ho Fellowship to support his study in geriatrics. Dr. Chen has gained extensive experience serving older adults in the community, residential care, and also infirmary units. Dr. Chen's research interest has been on the development and evaluation of community-based rehab programs, like the chronic disease cell management program, the full management exercise program for older adults, and also other services for adults with older adults with COPD and chronic heart failure. So his research is really covers a lot of different chronic illnesses, and today he will be sharing his more recent work, which is with developing physical performance assessments like walking, balance, functional performances for older adults with dementia and cognitive impairment. So without further ado, I just pass it to Dr. Chen to lead us through, all right? And
Okay.
towards the end, I would expect questions and answer, all right? And we normally can afford to have a session of like 1 hour 15 minutes to 1 hour 30 minutes, all right?
Mm.
So if Dr. Chen, after Dr. Chen finish it, then I will keep the time around that time. Then we will have a Q&A, depending on his presentation. All
Mm.
right, thank you. Dr. Chen, please.
Okay, so thank you very much for Andrew's kind introduction. So it's my pleasure to be able to join PolyU again. And also it's also my pleasure to be able to share with you my recent research interest, which is the falls in older adults with dementia. Okay, so let's start. So here are the outlines for today's seminar. So first of all, I would like to introduce the prevalence of falls in older adults with dementia, OwD, and I will tell you how common the problem is in this population group. After that, I will talk about risk factors for falls in older adults with dementia. What are the possible causes of falls in this population? And then we'll move on to another very important topic, which is very interested by most of the clinicians, the falls preventions interventions for older people with dementia. Do we have a very effective way to prevent falls in this population? We will take a look at into this matter later. And then we'll talk about some of my pilot studies that have been done before, which is exploring and developing some assessment tool to identify physical dysfunction or impaired physical performance related to the increased fall risk in older people with dementia. And lastly, we'll talk about some implications for future studies and some clinical implications as well. So dementia is a very common geriatric syndrome in older population. According to the reports published by the Alzheimer's Disease International in 2015, we have one new case of dementia every 3 seconds in the world. And by 2050, over 150 million of people are living with dementia. And actually, a lot of people living with dementia are actually residing in Asian countries. So according to this report, more than 22 million people with dementia are living in Asian countries. And Hong Kong is the same, okay, around more than 10% of older people are having dementia or different levels of cognitive impairment. So you can see that these conditions affect a lot of people, older people in the community. Falls are actually another very important geriatric syndromes that affect a lot of older people. According to some previous data, the prevalence of falls in older people with normal condition is around 30%, but the prevalence is much higher in older people with dementia. So this slide shows you some the summary of the findings of previous studies done before on older people with dementia. So the annual falls incidence is around 60 to 70% in older people with dementia. So you can see that the falls are more common in older people with dementia, and that is around 2 to 3 times more common than the older people with normal conditions. For the fracture rate is also the same. It's around 3 times higher than normal older people with normal condition. So that's why falls affect this population group a lot. Okay? Falls are associated with a number of serious consequences, such as repeated hospitalization, nursing home admission, and premature death in those with normal condition as well as those with dementia. There are some previous studies done before showing that fallers living with dementia are 5 times more likely to be admitted to nursing homes. So that's why they need a lot of care to prevent falls. That's why we need to address this problem in this population group. Let me show you some studies done before on the incidence and the prevalence of falls in older people with dementia. So this study investigated the falls incidence in people with different types of dementia based on the diagnosis of dementia. So you can see the table on the left-hand side shows you the incidence ratios of people with dementia with different types of diagnosis. So for the people who have Alzheimer's disease, the incidence ratio is around 2 times more than the healthy controls. For those with vascular dementia, it's almost the same, okay, around 1.8 incidence ratios compared to healthy controls. And for those with Parkinson's disease dementia, the incidence ratio is much higher, okay, it's around 20 times more common than the people with normal conditions. For the figure on the right-hand side shows you the survival curve according to the time of first fall after the patients having a diagnosis of the dementia. Okay, so take a look at the red line here. You can see that the curve here is very steep, right? Which means that after the first diagnosis, they are very likely to fall much sooner than other people with different types of dementia. So when you take a look at the blue line, this is the healthy control. Green lines is those with Alzheimer's disease. The orange line is those with vascular dementia, and the purple line is those with dementia with Lewy body. So you can see that the time to first fall is much more quicker for those with Parkinson's disease dementia. When we group all the people with different dementias together, we can see that the prevalence of falls, the falls incidence for this group of population is around 66% compared to 36% for healthy controls. And the relative risk is around 3, okay, which means that people with dementia, regardless of the types of dementia, have a 3 times increased risk of falls compared to those with a normal condition. So what about the prevalence of falls in people with different severity of cognitive impairment? So this study is a more recent one, which recruited a larger number of older people with different levels of cognitive impairment. So they recruited over 1,400 older people with cognitive impairment or dementia. And then they asked the history of falls in the past year. So for the healthy controls, 25% of them fall in the past year, compared to 31% for those with mild cognitive impairment. For those with Alzheimer's disease or non-Alzheimer's disease dementia, the prevalence is actually much higher. Okay, you can see that the prevalence rate is around 50 to 64%. Okay, so you can see that the prevalence of falls in older people with Alzheimer's disease or other types of dementia are much higher than those with only MCI or normal condition. So let's take a look at the common risk factors for falls, okay, in older population in general. Okay, according to some previous findings, large studies done before on older people with normal condition, these are the possible risk factors for falls. Some of the risk factors are non-modifiable, such as age, female gender, having a history of falls in the past year. We cannot change these risk factors, but these risk factors are actually quite common and also highly associated with falls. There are also some modifiable factors, such as the impairments in physical function. Muscle weaknesses, poor balance, unstable gait, reduced walking speed are all common physical impairments that we can find in older population and are highly associated with falls. There is also some medical problems, such as taking more than 4 medications, or what we call polypharmacy. Some previous study also showed that if a person is taking medications such as antihypertensive, antidepressants, or antipsychotics, they are more likely to fall as well. Another very important risk factor is visual impairments. For those who have glaucoma or cataract, are more likely to fall as well. Cardiovascular conditions are also related to falls, such as people having orthostatic hypotension, syncope, arrhythmia. These are the possible cardiovascular conditions that affect fall rates. We also have some psychological conditions as well, such as fear of falling and balanced confidence. These factors are also very likely, very highly associated with falls. So if the persons cannot overcome some environmental hazards, such as uneven or slippery fall, having a poor lighting at home, they are also more likely to fall as well. Another factor which we would like to focus today is the cognitive impairment or dementia. Having a diagnosis of mild cognitive impairment or dementia is another very important risk factor for falls in older population in general. So these factors affect older population in general, okay? But are these risk factors also the risk factors for falls in those with dementia? This is the question for today. So I'd like to show you some studies done before, okay? Investigating the risk factors of falls in older people with dementia living in the community and residential care facilities. I've actually shown this study done before, okay? They recruited 140 older people with dementia and 39 healthy controls. And they separate them into different groups according to the diagnosis of dementia, such as Parkinson's disease dementia, dementia with Lewy bodies, etc. And then they perform some baseline assessment on the risk factors for falls identified in older people with normal condition. And then they follow them for 12 months to see whether they will fall in the next 12 months. So this is the result of this study. According to their univariate analysis, they have identified some non-modifiable risk factors, such as age, having a diagnosis of Parkinson's disease dementia or dementia with Lewy body, having a history of falls or recurrent falls in the previous 12 months, So these are the non-modifiable factors increasing the rate of falls in older people. There are also a number of modifiable risk factors, such as taking cardioactive medications, having a poor performance in gait and balance assessments. Corner scale is actually a scale to measure depressive symptoms. So having a depressive symptoms is also related to falls. Other factors such as autonomic symptoms, having atypical or severe autonomic neuropathy, symptomatic orthostatic hypotensions, some cardiovascular or autonomic problems, responses related to falls as well. So for the physical activity, it is actually a protective factor against falls. So if you perform more physical activity, the older person with dementia will have a reduced risk of falls. So you can see that there are a number of modifiable risk factors for falls in older people with dementia as well. This study tried to focus more on the cardiovascular and autonomic responses. So that's why they have a lot of assessment in this aspect. So what about other factors such as physical function, psychological conditions, etc.? Whether these risk factors affect the risk of falls in older people with dementia? Let's take a look at the other study, okay? So these studies investigated a number of risk factors potentially affecting the risk of falls in this population group. So they performed some assessment on neuropsychological, physical, and functional mobility to assess these functions. So in these studies, they recruited 177 older adults with mild to moderate cognitive impairment living in the community. So they have relatively high older age. The mean age is around 82. And actually, their cognitive impairment is not as severe. The mean MMSE is around 22 to 23. So they recorded the full history in the next 12 months using different methods. So at the end of 12 months, they recorded around 344 falls. The fall rate is around 2 falls per person year. 64% of the participants had at least one fall, and 41% fell twice or more. So according to the univariate analysis of this study, so these are the possible risk factors for falls of the participants. There are a number of personal characteristics such as the use of walking aids, having a fall history, self-rated balance and general health, arrhythmia, taking more than 4 medications, and taking CNS acting medications are related to falls. There are also a number of neuropsychological functions as well, such as visual-spatial function, visual search, divided attention, mental flexibility, having depressive or anxiety symptoms, and false efficacy. Okay, so these functions, these problems are also related to falls as well. There are also a number of physical functions investigated in this study, such as reaction time, posture straight, static standing balance, coordinated stability, functional mobility, lower limb strength, walking speeds. So these are the possible risk factors for falls, okay, in this population group. But what about if we can group all these risk factors together to see which one is more correlated to falls in this population? So this study has actually done a multivariate analysis. So they just extract some risk factors from each category that is highly associated with falls, according to the univariate analysis, and put these risk factors into the multivariate analysis. And then they compare the associations between these risk factors and falls in this population group. And then they found that postural sway on foam, which means that we ask the patients to stand on a foam and ask them to stay balanced. Coordinated stability is another measures for balance. They just ask, it's a test for limit of stability. They ask the patients to move the centers of pressure or center of mass within around the limit of stability. Okay, it's also a measure for balance. And geriatric depression scale. Okay, depression symptoms is also another important risk factor for falls in this group of participants. So according to the results of the multivariate analysis, we can see that balance is actually a very important risk factor. Okay, so we believe that the central neurodegenerative process found in older people with dementia may contribute to the impaired gaze and balance in this population group, because they have reduced cognitive processing speed, and at the same time they may have an impaired sensory motor system because they are rather old. Okay, so when they have some impaired motor planning and responses required in walking and maintaining a balance, they have increased risk of falls. So this study actually suggests that postural strain may be the surrogate to measure the overall sensory motor performance, which will be related to the risk of falls in this population group. So this is a related, another study done by the same group of researchers, which is related to the previous study. Okay, they used the same group of participants, and then they investigated some physical and cognitive possible risk factors associated with falls in a group of people with mild to moderate cognitive impairment. The first thing they did is to investigate the associations of different neuropsychological domains and falls in this population group. So according to the findings, you can see that cognitive functions of domains such as processing speed, executive function, visual spatial ability, and affects are the possible risk factors for falls in this population group. And among these different cognitive or psychological domains, executive function is actually the strongest predictors of falls among all the risk factors related to cognitive function. So they speculated that if the person with dementia having a poor executive function, they have a reduced processing speed when responding different environmental hazards. And they also have some reduced attention to maintain balance. So that's why they have they're more likely to have multiple falls. And they also found that those with poor executive functions have usually significantly worse vision, reaction time, reduced muscle strength, increased postural rate, and reduced stability in coordinated way. Okay. And this study actually did a very interesting analysis as well, because they tried to incorporate different functional outcomes into the models of multivariate analysis. And they actually found that reaction time and postural rate on foam surface significantly moderate the relationship between executive function and multiple falls, which means that when they put reaction time and postural rate into the model of analysis, the relationship between executive function and multiple falls disappeared. So that's why they proposed that reaction time and postural rate may be the possible important risk factors that may highly associated with falls in this population group. So what about those people who are living in residential care facilities? So this is another study done before as a large study. They recruited more than 2,000 older people living in residential care facilities. They are newly admitted to nursing home, and they collected the fall data for 2 years. So the fall rates in average for those with dementia was around 4 falls per year, compared to 2.3 falls per year for residents without dementia. After adjusting all the basic characteristics such as ADLs, history of medical conditions such as stroke, etc., etc. So you can see that those who are living in residential care facilities also have higher chance of falls when compared to those without dementia. So what about the possible risk factors of falls for those who are living in residential care facilities? This study recruited 109 residents with cognitive impairment, and they found that the prevalence of falls is around 49%, and fall rate is around 2.5 falls per person year. 20% of them were injured resulting from a fall, and 2% of them had a fracture as well. So these are the possible risk factors that are independently predict falls in this population. The use of antidepressants, increased posture rate with eye closed, poor attention and orientation, and having anxiety symptoms. So if the person have all these 4 risk factors at the same time, okay, the risk of falls is 100%. So if the person is very unfortunate having these problems at the same time, they are very, very, very likely to fall in the future. So in summary, we've identified a wide range of risk factors associated with falls in this population group, including physical, psychological, cognitive, medical, and cardiovascular conditions. Okay, but we may also identify or realize that the risk factors for falls in older people with dementia may be slightly different from those with normal condition, because some older people with dementia may have behavioral and psychological symptoms. So that's why depressive symptoms or anxiety may be more popular in this population group. And we found that these psychological symptoms are very likely to predict falls in this population group. Another factor such as impulsivity is also very common in older people with dementia, and this factor is also associated with falls as well. But according to this, to the findings of these previous studies on the risk factor for falls, we can see that the findings and results are relatively inconsistent across studies. Okay, for example, some study identified, like for example, having antidepressant is a risk factor for falls, but in another study, they didn't find that the relationship between antidepressants and falls. But we can quite pretty sure that physical performance such as balance, gait, functional mobility may be consistently associated with falls in this population group. So that's why we may need to address this problem when we are going to provide some interventions to prevent falls for this population. So now let's take a look at the possible interventions to prevent falls in this population group. So what are the possible effective interventions to prevent falls in older population in general? The first thing is multifactorial interventions. According to some systematic reviews, multifactorial interventions can reduce the rate of falls by 23%. Exercise is a very important component as well. It can reduce 21% of falls in those who are living in the community. And you need to provide some balance or muscle strengthening exercise. And actually, highly challenging balance exercise is the core component of your exercise programs to prevent falls. So if you can incorporate some highly challenging balance exercise 3 hours per week at least, you can reduce 39% fall rate in the older people living in the community. So that's why highly challenging balance exercise is very important. But are these interventions approaches also effective in those with dementia? I will put a question mark here because according to the current data evidence, we cannot actually identify a very effective way to prevent falls for older people with dementia. So this study is a big study done quite a while ago. They incorporated a 1-year multifactorial individualized risk factors identification and intervention. So it's a very comprehensive way to prevent falls for older people with either normal conditions or cognitive impairment or dementia. So these are the strategies they use in these interventions. First of all, they use multidisciplinary assessment. They incorporate doctors, nurses, PTs and OTs to assess the functions of the older people. And they also conducted some medication review. They have optical corrections done by another doctor. And they also provided some supervised and unsupervised home-based exercise for 12 months. And the OTs in the team also provided some home hazard modifications to the participants. But these interventions were provided according to the risk factor identified in the participants. So the the type of interventions that they receive by the participants may be different from each other. Okay, so they recruited older people who are diagnosed with cognitive impairment or dementia, presented to A&E after 4, having MMSE lower than 24. And they did not recruit those who are not able to walk or without main informants who are in contact with patients at least twice per week. So this is the characteristics of the participants. The mean age is around 84. Most of them are female. The mean MMSE score is around 14 to 12, which is quite low. Okay, and most of them have a proper diagnosis of dementia as well. Okay, so at the end they recruited around 270 participants. Many of them have multiple chronic conditions, and many participants have multiple falls in the past 6 months. So according to their assessment, individualized assessment, they have identified a number of risk factors for falls for the participants. And in total, they identify over 1,000 risk factors for falls, and the median number of risk factors per participant is around 4. Okay, and most of the participants have balance or gaze problems. Okay, you can see the percentage here. 99% of them have balance problem. Okay, for those who are attending an intervention group or control group. Over 80% of them have environmental fall hazards, and over 70% of those who are attending the intervention group have the medication problem. Okay. So here are the main findings of this study. The compliance to the tailored individualized interventions is around 39 to 86. For those who are attending home-based exercise due to their balance or gait problem, 61 to 64 of them comply to the home-based exercise, which is not bad. Okay. The intervention groups significantly improved their genetic gaze score, environmental risk factors, ASISTO when compared to control groups at 3 months. So these are the short-term improvements of the participants. Okay, but what about the long-term improvement at 1 year? So you can see that the patients falling at 1 year, there's no significant improvement for the intervention group. And so does the other outcomes for falls, such as the median number of falls, median time to first fall, etc., etc. So according to the findings of these studies, the multifactorial intervention is not effective in reducing falls in this population group. So, these interventions has been provided to those with normal conditions, but according to this study, they did not find a significant reduction in falls in the participants. So they expect that the multifactorial falls prevention interventions may be less effective in those with cognitive impairment. So they propose some possible strategies to improve, such as providing longer durations of physical exercise, for example, more than 3 months, which may be more effective for the interventions to reduce falls. So I think exercise is very effective interventions to prevent falls in older population in general, right? So what about for those who are having cognitive impairment and dementia? So this is a systematic review done by our colleague, Dr. Freddie Lam, and also Professor Marco Pang. They investigated the effects of exercise in improving some physical functions and also falls in the people with cognitive impairment and dementia. So these 2 graphs shows you the effects on balance. Okay, so you can see that they recruited 6 studies, and they found that the pooled effect for bird balance scale is positive, that favors exercise. For the functional reach test, which is a test for dynamic balance, the pooled effect is also positive, that favors exercise. which means that physical exercise can actually improve balance, no matter how you measure it, in older people with dementia. The same in this systematic review, they also found that physical exercise can significantly improve floor-related physical functions such as balance, muscle strength, and functional mobility. What about falls? Okay, unfortunately, they did not find a positive findings. Okay, according to the 3 studies they recruited in the systematic review, the number of fallers after attending these interventions is not effective. It's not significantly reduced. Okay, so there's no significant reduction in the number of falls, number of fallers, fall rate, time to first fall after the intervention, after the exercise intervention. They try to explore the possible reasons, and actually most of the participants adhere to the exercise program, so they don't have any problems with the compliance rate. And physical exercise is safe for them to perform because most of the studies did not report a lot of adverse events associated with physical exercise. So according to the findings of this systematic review, we can say that the improvement in physical performances, such as gait or balance, do not translate into falls. So it's very sad to hear this piece of information, but do we have any studies that shows positive findings? Yes, we do. So this is one of them. This study investigated the effects of long-term exercise on the physical functioning and mobility of home-dwelling patients with Alzheimer's disease. They tried to explore the effects of the use and cost of health and social services, and falls are actually one of the secondary outcomes of this study. So they recruited a number of people with Alzheimer's disease who are living with spouse, who are able to walk independently with or without walking aid, had at least one of the following problems, such as having a fall in the past year, reduced walking speed, or an intentional weight loss. Okay, so they randomized the participants into 3 arms. The first group is having the home-based exercise, the second group is having group-based exercise, and the third group is having usual care. And after randomizations, they received 2 types of exercise intervention that lasts for 12 months. So for the home-based exercise, it is a goal-oriented, individually tailored exercise program that tailors to the needs of their daily functioning and mobility. They incorporate some ADL-related exercise such as climbing stair, balance training, transverse training for the participants. So the participants were asked to perform this exercise 1 hour per session and twice per week. For those who are attending the group-based program, they perform some endurance, balance, strengthening exercise, as well as some exercise improving executive functioning. Okay, it is group-based with 10 participants per group. The program is led by 2 physiotherapists, 1 hour per section, and also twice per week. So in the home exercise group at 1 year, they found that the participants have significantly reduced functional dependence as measured by FIM at 6 months and 12 months. For both home exercise and group exercise groups, the participants have significantly reduced the number of falls at 12 months. Okay, but not other secondary outcomes such as hospital admission, fractures, and hip fractures. Okay. But at the same time, they did not find a significant improvement in general mobility as measured by SPPB. Okay. The study also reported low attrition rates, and the participation rate is actually quite high for both exercise group, but slightly higher for those who are attending the home exercise group. So over 92% of them participated at least half of the sections, compared to 78%. So after listening to some studies done before on the interventions for fall prevention for older people with dementia, can we identify some possible issues related to the intervention studies? So first of all, for the interventions aiming at fall prevention for this population group, did these interventions tailor to the problems and needs of older people with dementia? So actually, most of the previous studies just use some interventions that have been shown effective in older people with normal condition, and applied it or just copy and paste to those who have who have dementia. So we think that this approach may not be appropriate because, as I said before, those with dementia may have a unique set of risk factors for falls. So this type of copy and paste may not be a good way to prevent falls in this population. And also another factor, the duration may be slightly too short. And for those who have dementia, if you want them to perform exercise to prevent falls, we may need to consider to incorporate some longer duration exercise that can last for example, 6 months or even 12 months, okay, to make it more effective. And also another factor is that, do we need to engage caregivers in the interventions? So according to some pilot studies, engaging with caregivers in the interventions may be a very important component in the interventions to make it more effective. So in the studies that target at falls in the future, you may need to consider how to engage caregivers of the patient. Another factors associated with the fall prevention study is that fall risk assessment. Do we have a thorough investigation of the risk factor for falls for this population group? I think not. I think we need to provide more, conduct more studies investigating different risk factors for this population group. Another problem is that, do we have a proper assessment tool specifically designed to assess, for example, the physical performances for those who have dementia? It's no for me too, because most of the assessment tools will apply to older population in general, but may not be applicable to those with dementia. I will talk about it more in the following part of the presentation. And also the assessment tool may not be sensitive enough to predict falls too in this population group. So that's why it's very important for us to develop some assessment tool that can assess the physical performance of the older people with dementia, and also use these the results to predict falls for this population. So there are a lot of challenges when we assess physical performance for this population group. So if you are the PTs, and you can actually share a lot of feelings and experience how difficult it could be to assess physical performance. Because most of the older people with dementia have reduced attention, they were not able to remember instruction and testing procedures. They may have some behavioral and psychological symptoms. They cannot understand or comprehend instruction. They have reduced motivations. All these characteristics may affect the accuracy and the consistency of the test results. So that's why we may need to consider to develop some assessment tool that can tailor to the needs and characteristics of older people with dementia. So these are the possible recommended approaches when assessing physical performance of older people with dementia. First of all, we need to use a sequential approach. We need to separate the test step by steps and start from simple steps to some more complex step in the later part of your assessment. You may need to also consider to use some external cues to assist the patients to perform the task, such as using verbal or physical cues. We need to consider to develop some tools tailored to the specific needs of the characteristics of the people with dementia. We may need to incorporate tasks with shorter durations, because most of them have short attention span. Okay. We may need to consider to use some simple and careful instruction, try to use some non-verbal focus instructions or repeated task demonstration. We also need to incorporate some simple functional daily tasks that most of the older people with dementia are familiar with. So they don't need to learn new tasks before they can perform the test for you. So in this part of the presentation, I would like to share some of the pilot study that I've done before. Okay, I tried to validate some mock tests for older people with dementia. Okay, and we have some modifications to the delivery of the testing procedures, which I will show you later. So first of all, how we can assess walking performance in older people, and why do we need to assess walking performance? Walking performance is a very important indicator of the general well-being of older people, because poor walking performance is a determinant of falls, functional dependence, cognitive decline, and mortality in older people in general, and also older people with dementia. So how we can assess walking performance clinically? Okay, we usually use walk tests such as 2-minute walk test, 6-minute walk test, and 10-minute walk test. So when we use these walk tests in older people with dementia, there are some positive, there are some pros for we to use. So first of all, these walk tests are relatively clinically friendly. They are easy to administer. They are highly similar to ADL, so they don't need to learn a new task to perform the walk test. So that's why we can reduce the testing procedures and also instructions provided to the participants. So we believe that walk tests are more suitable for older people with dementia who have limited cognitive resources to perform. However, the psychometric properties of walk tests have not been thoroughly investigated in this population group, and we don't know how to provide guidance or cueings to facilitate the participants to perform the walk test. So that's why we have this study. Okay, this pilot study aims to investigate the kinematric properties such as test-retest, interpreter reliability, construct and long group validity of 2-minute walk test, 6-minute walk test, and 10-minute walk test in older people with dementia. And we also try to examine whether a progressive queuing system can facilitate older people with dementia to complete walk tests. So in this study, we recruited older people with a diagnosis of dementia or Alzheimer disease. They were able to walk independently with or without walking aids. And when recruited the participants from the daycare and residential care facilities. For those who have acute exacerbation of some medical problems, neurological problems, severe hearing and visual impairment were excluded from our study. The participants were asked to walk on a 15-meter corridor for 2 minutes or 6 minutes to measure the score of 2-minute walk test and 6-minute walk test respectively. Okay. So for the 10-meter walk test, we measured the performance of the 10-meter walk test within the 2-minute walk test and 6-minute walk test. Okay. We measured the speed of walking when the participants walked for the middle 10 meters of the corridor in the first leg of 2-minute and 6-minute walk test. Just because we want to save time, because most of the participants that we recruited have very poor attention span. They won't spend time for you to complete all the tests for 2 hours. So we try to shorten the testing occasion to try to engage more with the participants. So that's why we incorporated the 10-meter walk test into the 2-minute and 6-meter walk test. Okay, so all the participants complete the walk test in 3 separate testing occasions under 2 independent raters. So we incorporate this progressive queuing system into our test. So whenever the patients started to deviate from the path, run or slow down or stop walking during the test, we provide different level of cues. Okay. So for example, the queuing system ranging from level 0 to level 6. For level 0, we provided no cue. But if the patients cannot follow the instruction or procedures, we will move on to the level 1. We provide verbal cue. And then if this is not successful, we move up the queuing system until the last queuing system, last cue, which is a complete physical guidance. Okay. After providing a cue, we provided a few seconds for participants to respond to the cue. If the patients can respond to the cue, we will stick with the level of queuing, okay, for the rest of the test. If the patient cannot follow the cue, we will move up to another level, okay. We also incorporate some practice trial for us to understand the level of queuing required to facilitate the patients to complete the test. So let me show you how we conduct some the progressive queuing system. So in this video, I will show you how we provide the level 1 of verbal queue. Okay, let's take a look. So it's actually quite simple. We just ask the patients to just come back and ask them to stay concentrated into the task that we want them to do. Because during the walk test, we need to ask the patients to walk back and forth between 2 traffic cones or at the endpoints of the corridor. And most of the time, the patients forget to turn at the end of the corridor. So that's why we need to provide different levels of skills, usually at the end of the corridor. So in this level 1 of verbal cue, we just ask the patients to go back and and keep walking, etc. So it's very simple. So let me show you the level 3, which is one of physical cue. So yes, so on top of providing physical cue, we also tap on the patient's shoulder to get their attention and to draw their attention and to ask the patients to keep walking, to go back, okay, to have a turn at the end of the corridor. So this is level 3. So if we provide repeated this type of physical cue during the course of the test, the patients will have what we call level 4, okay, repeated or intermittent physical cue. So this is the result of the findings of our pilot study. We recruited 39 participants. The mean age is quite large, it's quite high. They have a mean age of 87. And the mean MMSE is around 13. And most of them are female. And most of them use no walking aids to ambulate. Okay, and many of them, actually 28% of them are outdoor walker, which means they can walk independently outdoor. So what about the reliability of the walk test? Our study shows that all these walk tests, 2-minute, 6-minute, and 10-meter walk tests, are reliable. They have very high test reliability and also inter-rater reliability. We have a slightly lower inter-rater reliability for the 10-meter walk test measured in 6-minute walk test. Okay, it is because we identify some outliers which perform quite strangely, weirdly during the walk test. According to some post-hoc analysis, we found that these outliers usually walk without aids. They are highly mobile. They have severe dementia, very low MMSE score, and also they have behavioral symptoms as well. So they behave quite strangely during the walk test. They just stop walking immediately or suddenly start running. So that's why they have a they affect the reliability of the test. But after removing these, we identified 2 outliers. After removing these 2 outliers from the data set and we reanalyze the inter-rater reliability, we can see that the reliability coefficients increased to over 0.8, I think. Okay, so it becomes reliable according to our standard. And also these walk tests are strongly correlated among themselves. And these walk tests have good correlations between with the functional outcomes such as general mobility measured by elderly mobility scale, balance control measured by bed balance scale, and also ADL measured by modified Barlow index. For the known group validity, both 2-minute and 6-minute walk tests were able to distinguish participants who did not require walking aids to ambulate, and those who need stay, quadruple, or frame to ambulate. All the walk tests, including the 10-meter walk test, were able to distinguish participants who were able to walk outdoor and those who could not. So we believe that the validity of these walk tests are quite good. Okay. So what about the cues provided during the walk test? So you can see that by in the 2-minute walk test, most of the time we provided level 1 of cue, which is the verbal cue, followed by some of them, around a quarter of the participants did not require any cues to complete the test. And some of them require level 2 or level 3 of cueing. For the 6-minute walk test, again, most of them require only verbal cues. But we can see that there are more participants require higher level of cueing, okay, which is shown here in the pie chart, because it's understandable, because 6-minute walk test is a longer test compared to 2-minute walk test. So some patients may start to forget what they're doing during the test. So we have to keep reminding them, drawing their attention back to the test. So it is actually expected to for us to provide more cues, more assistance during 6-minute walk test compared to 2-minute. So we also see that we provide the cues consistently across the raters or within the same raters in different testing occasions. So, so we believe that the queuing system is quite reliable to provide. So in summary, all the walk tests included in this study, the 2-minute, 6-minute, and 10-meter walk tests, have excellent test-retest and inter-rater reliability in measuring the working performance in older people with dementia. They are generally valid and can differentiate older people with dementia receiving or using different walking aids and also walking status. And also the progressive queuing system is a reliable tool to facilitate this population group to complete walk test. So I have also conducted another pilot study which investigate the use of backward walking test. Okay, so backward walking is a daily task that we need to do every day. Okay, but it actually demands more balance or gait control and more cognitive resources because of the reduced visual input when we walk backward. Okay, so that's why we have the backward walking test. And it has been developed and validated in older people with normal condition, but it is not validated in older people with dementia. And we don't know whether this test is able to identify older people with dementia with balance deficits, gait impairments, or increased risk of falls. So that's why this study aimed to investigate the kinematic properties of the backward walking test in this population group. So the methods, the participants, and more likely the same compared to the last pilot study. So this is how we conduct the backward walking test. Okay, the participants were told to walk backward at your usual and comfortable speed along a 6-meter straight level corridor. Okay, so this is the setup for the backward walking test. Okay, so the patient were asked to walk from starting point A to the ending point B, and then we measure the backward walking speed between point C to point D, which is 3 meters long. All right, only. Okay, so for the first and the last 1.5 meter of the corridor, they are reserved as the acceleration and the deceleration phase of the walking. So we conducted 3 trials, and the average speed of 3 trials was calculated. In this walk test, we try to simplify the progressive queuing system because we believe that the backward walking test is actually quite short. Okay, most of the participants can finish it within 30 seconds. So we don't think that we need to provide a lot of higher level of cues during the test. So that's why we have these simplified versions. We only have 4 levels. Okay, the maximum level is level 3, intermittent physical cues, which we tap the shoulders of the patients repeatedly during the test. Okay. So here are the results of the pilot study. So the mean age is around 83. The mean MMSE score is around 15. And again, most of them use no walking aids to ambulate. And actually, we have around 27 of them or 8 participants have fallen in the past year as well. So this is the results for the reliability as analysis. We can see that this test has very high test-retest and inter-rater reliability. For the cues that we provided during the backward walk test, the majority of the participants require no cues or verbal cues during the test. So we also found that the BWT was moderately correlated to the balance scale and also strongly correlated with the 10-meter walk test and also the TUG, time up and go test. The test was also able to distinguish those who are using no walking aids against those who use any walking aids during the test. However, we are not able to identify fallers using this test. So although it's, so you can see this part of the table, for those who have fallen in the past year, they actually appear to perform quite bad in the test when compared to the non-fallers. But we did not find a significant difference in the BWT between these two groups. So can we use the BWT to predict falls in this population group? So we actually compare the predictability of falls between the BWT and other functional tests such as PBS, 10-meter walk test, and TUG. We did not find a significant association between the results of these functional tests and also the fall status of the participants. But you can see that the p-value is quite low. Okay, we can actually say that the BWT and 10-meter walk test are actually marginally able to predict falls in this population group. So because in this pilot study, we just recruited 13 participants, so we expect that we need to conduct another bigger studies to investigate the predictability of the backward walk test and also the 10-meter walk test for falls in this population group. So to summarize, the backward walk test is a simple tool that requires little preparation and equipment to administer. So it's easier for clinicians to administer this test. So we think that the BWT is a safe and reliable and valid test to assess balance and gauge performances in older people with dementia. The BWT can distinguish older people with dementia who have different ambulatory statuses based on the use of walking aids. And we need more data in the future to have a better study to investigate whether this test can identify fallers who have a history of falls in the past year. So this is the summary of this presentation, of this seminar. Okay, we can see that falls are highly prevalent in older people with dementia. The risk factors for falls in older people with dementia are unique, complex, and also multifactorial. According to the current evidence, the strategies to prevent falls in older people with dementia are generally ineffective. Sad to say that. Okay, that's why we need to have more studies in the future. We need to develop some dementia-specific assessment tools that can predict falls. We also need to conduct some new interventions that can actually reduce fall effectively in this population group. So these are references, and this is the end of my presentation. Thank you very much.
So thank you, Dr. Chen. Just give you applause for.
Thank you, Andrew.
Everybody is mute, but
okay.
The very systematic presentation and a lot of reviews that a lot of knowledge about the whole field. And I can see you developing these tests, which are not easy at all.
Yes,
to do.
Very, very challenging.
Very challenging. Okay.
Very challenging.
All right, so now we have quite some time for Q&A, at least maybe like 15 minutes that we can spend on Q&A and also sharing about this field as well. So anybody can please remember to turn on your mic when you speak, and if possible, you can also show your face. For those who can't can't, it's not convenient, you can type in the chat as well. I will alert the speaker, right, about your question. Thank you. So please go on.
So I can see some questions from in the chat, right?
Yes, yes.
First of all, who is it? Let's see.
First is actually Frank Lai, our colleague.
It's Frank. Okay. Hi, Frank. So for older adults with more advanced level of dementia, like the one became environmental dependence, what is the perspectives of literature in fraud prevention and exercise for them? Okay. Well, in fact, most of the current evidence are on those who have either mild cognitive impairment or mild to moderate dementia. So we have no clue how we can provide fraud prevention interventions for those who have severe dementia, because as you can imagine, it's very, very difficult for them to reduce falls because they have so many different problems such as behavioral, psychological problems. And at the same time, they have a very significant reduction in their physical performance as well. So they're relatively frail, weak. They are at the later stage of their life, I could say that. Okay. So if they have become more environmental dependent, they are more dependent in their function level, is really, we don't really have a way to reduce falls. And so I actually cannot show any evidence or information for you guys. But according to some experts in the field, they actually say that we need to reconsider whether we need we should focus on falls is outcome measures for those who have dementia, especially for those who have severe dementia. Because to a certain extent, we need to accept that some falls in older people with dementia are not preventable. Okay, so so if we need to target falls in this population group, we may need to shift our focus to those who have milder dementia or mild cognitive impairment, because we do have some more effective or even cost-effective ways to prevent falls.
Okay. There's another question about the type of test that we can use with people with dementia, which is uses
either TINETI or BBS. So these two tests are actually validated in people with dementia. So they have good reliability and validity as well. If I need to choose one, I would choose BBS. I would choose per balance scale. But of course, they have some limitations. But I think per balance scale is more sort of sensitive in terms of the balance performance for older people in general, as well as those with dementia. But I actually use this BBS as well in this population group, and I can actually foresee the difficulties, because some of the tasks in the BBS is slightly more difficult for them to perform, and sometimes they just refuse to do some tasks, such as single extending. If they have a very increased risk of, or fear for falling, they refuse to perform these tasks. So we may need to consider some more different ways to assess balance in this population group. We need to have some more tools, okay, if they refuse to perform one, okay? So which assessment tool is better and consistent?
You have answered, I think. And any tips, and also find it difficult to complete BBS in nursing home? Somebody said.
Yes, I think it's true, because I actually did have some experience performing BBS in those with dementia. Not all the people with dementia can actually comply with the BBS. So if it is the case, then we need to find some other ways to assess balance. We may need to consider other tests that are more simple for older people with dementia to perform, such as functional reach, or just observing their postural sway in static standing or standing on form. These may be easier for them to adhere to the test. So that's why I said that you need to consider, you need to have a big assessment toolbox, okay? So you can actually incorporate different tools in your toolbox. So if one of the tools fail, then you have to move on to another tool.
Okay. And somebody asked about the ceiling effect of BBS. So is this maybe the person's experience is that there may be ceiling effect? Is that right?
Yes. Because BBS was originally developed for those who are staying in the hospital. So that's why the BBS consists of some tasks that are relatively simple for those who are living in the community. So it really depends on which population group you're investigating. So if you're evaluating those who are living in or staying in hospital or residential care facility or daycare facilities, these two may be okay. But for those who are living in the community, you may need to use some more sensitive tests. But it really depends on their adherence to the test. So I cannot say that which one is the best one, but I think backward walking test may be a potential better one because, as you can see in our data, it is highly correlated with some balance tests and also other functional tests, and it is also potentially predict falls. So you may start to consider this test as well. Okay.
So there's one more question about from Ivan O. That whether the mechanism of fall is the same or different, in people without dementia. So I think a mechanism of fall maybe he's referring to the reason of fall or how they fall. All right. Is it the same?
Do you mean that whether they have higher risk of having a trip or sleep when they're overcoming some environmental risk factors? I think there's no such piece of information so far because falls in people with dementia is a relatively new topic. Okay, so we don't have much information about how they fall. But we can expect that they have poorer ability to overcome these environmental hazards because they have poorer cognitive function, they have poorer executive functions, they cannot prepare themselves to overcome these hazards, and they cannot have a better planning to how they can reduce the fall risk. So that's why they may have high chance of falls. So I expect that the mechanism may be slightly different, but it's depending on more study on this topic.
Okay.
Thank you. So I can see there's another questions early on. Any tips in exercise training with cognitive training in working with high risk OwD? Any tips in exercise training? I would say that, as I said before, actually engaging caregivers during the training is very important. No matter whether it's the training is a group-based or home-based training, you still need to have at least an assistant, a maid, or a caregiver next to the person to perform the exercise together. Okay, so because I think the characteristics of the older people with dementias may affect their adherence to the exercise training. Sometimes they need some third persons to remind them to, okay, this is time for you to do the exercise, right? And sometimes they may just forget how to perform the exercise, even if you provide all the information like the printouts, pamphlets to the patients to perform the exercise. So it's very important for them to have a person next to them to assist them to do the exercise. So that's why even if you want to do a group training for those with dementia, I think it's better for you to have for example, caregivers to attend the group training and assist them to do the exercise together. So also, I think older people with dementia or different levels of cognitive impairment takes longer time to learn how to perform exercise training. Okay, because exercise may be new to them, they need time to learn how to perform a particular exercise or skills. So that's why we expect that they may need more time to have the effects of exercise. Okay, so for example, according to the previous literature review, balance exercise take around around half year to have an effect on force in older population in general. So we expect that the people with dementia need more time, like 9 months or even 1 year, to make it more effective. So so that's why we need to consider the time frame for when we are conducting the exercise for this group of population.
Okay.
Actually, it raises another concern, which is the cost effectiveness as well.
Yeah. One more question about whether it's appropriate to use the time up and go test, which is, I think, very popular with the people with elderly with dementia.
Yeah, it's a very popular test to detect general mobility in older population. It is actually validated in older people with dementia as well. So, but in some validation studies, they actually report that some people cannot adhere to the UG test. The problem usually arises when they need to turn at the end of the corridor. They just forget. Okay, so if they forget, you have to remind them, but it will just prolong the duration for the patients to complete the test, which means the forgetfulness actually affects the result of the test. So that's why if you want to really perform TUG tests on this population group, I will advise you to run 1 or 2 practice trials for the patient first. Okay, to see whether they can actually adhere to the testing procedures without any assistance, okay, without your assistance. So if they just, for example, they just really forget how to turn at the end of the corridor, and you need to provide the verbal cue or physical cue, then you need to redo the test again and apply your verbal or physical cues, and to see whether they can perform slightly better than the first than the first one without any assistance. So that's why you need to spend more time to repeat the test until we can get it right, and when the test ends, can actually reflecting the true performance of the patient.
Yeah. Part of the time may be spent on responding to your instruction and cue.
Yes, that takes a lot of time.
Okay. Yeah, there's a longer question about can you tell us more details how to assess the reaction time and postural sway in form? Right.
And they seem to moderate the relationship. Okay.
Yeah.
Reaction time. So according to that study, they just they have a very comprehensive assessments for 4 risks. So one of them is to assess the reaction time, which is quite simple. It's a hand reaction time. Okay, they just ask the patients to watch the screen, watch like a light bulb. Okay, they just light up, and then you ask, and the participants were asked to press on the button on the light bulb. Okay, to switch it off. Okay, this is the hand reaction time. So for postural sway on foam, they just ask the patients to, so we have some standard foam for the patients to stand on to assess the balance. This is usually not fagogao, okay, it's much more spongy, okay, that we use for balance exercise as well. So we just ask the patients to stand on the foam and stay in the standing position as long as they can, for example, 30 seconds or even 1 minute. And then we measure the time that they can stay on the foam. So this is how they assess the reaction time and process rate on foam. Okay. But I think there are some other ways to assess reaction time, but that actually requires some more sophisticated equipment, which is not very clinically friendly. So I think they have already incorporated some the one that is easiest for clinicians to use.
Okay. All right. So Wing has answered, I think, almost all the questions.